I hope by the end of this talk that you're able to understand how mental health impacts someone's decisional capacity. I recognize that term mental health for some is a hot button term. Relax. I like to use the term as a way to describe the full impact of a disease on a person's brain, not just their cognition, not just their emotion, but even their consciousness. And broadly, I would probably call that mental health. I like to think, in fact, as dementia as a disorder of consciousness. That's a separate talk that you can invite me to give later. I want you to be able to define what is decision-making ability, what's capacity, what's competency, recognize the differences between them. I want you to have a working knowledge about how to assess capacity, um, uh, uh, and have a working knowledge in how to incorporate the techniques of assessment into your practice. So let's begin with a case that I think probably resonates with many of the clinicians here, which is a 85-year-old woman who's hospitalized for pneumonia. She's now ready to be discharged. Her daughter comes back from a visit to her mother's apartment to get things in shape, and she discovered that there are two mispaid bills and two fill bottles of medications that had not been taken. So the case manager, the discharge planning manager, says, "Well, do you think we can send her home?" I would submit that this is a decision. In other words, you have to decide whether this patient is able to manage things at home. And you've got some evidence to make you concerned that she might not be able to manage things at home, namely potential impairments in the IADL of finances and the IADL of medication management, two cognitively intense instrumental activities of daily living. So, being a keen person wanting to keep your service light and get those beds churned, so you said awful word that seems to have entered our lexicon as clinicians, the churn. You present the patient this option. Let's have your daughter come over to your house, set up your pills on a weekly basis, and help you with your finances. So you're going to try to solve that functional impairment with an intervention. And the patient tells you, no, I don't like that compared to what I do. I don't like people coming over to my place, my private place, and I don't want my daughter bothering. So you gave her some information, a decision to make, and she's made a decision. It's a very quotidian decision in some sense, not like a hot button inpatient treatment issue, although I would argue it's an incredibly important decision for her well-being and flourishing. So why does this case, as ordinary as it seems, but perhaps as common as it is, matter? Well, we think in liberal democracies, such as the one that we live in, that adults should make or at least participate in medical decisions if they want to. We have this ethic that the voluntary choice of a competent adult is a core ethic, not just of medicine, but of life. And we think that persons who are judged not capable of making a decision, not competent, need someone else to protect their well-being, such as a family member. Oftentimes we give that family member the title of being, quote, a caregiver. Sometimes we give them the sort of funky title of being a surrogate. Now, in between those who are judged competent, capable, having adequate decision-making ability, and not competent, not having adequate decision ability, are persons who need a support to make a decision. And this concept of supported decision making is one which I have a hunch you're going to learn about more in the coming years because our group is very keenly interested in it. We think it's a neglected but terribly important idea, namely that people have marginal capacity, and much like someone with a bum knee, bad eyes, whatnot, a little support helps them walk about, see clearly, etc. There's a legal framework around decision-making capacity, which I won't develop in greater detail. I do want to I want to emphasize, though, with incredible force, as much as I can, that there's no question the law, and this is a quote from the Maryland rule around diminished capacity, recognizes decisional capacity as a core component of making decisions about whether someone, for example, can live their life as an adult or needs a guardian. As physicians, we also assess decisional capacity in order to decide whether our patients have been adequately taught to make a decision about their care. And when we do that, we don't need a lawyer, we don't need a judge, etc. So let's go back to the case at hand. Let's kind of deconstruct what the patient said. She gave you a decision. She communicated a choice, no, and she engaged in some comparative reasoning. I don't like that compared to what I do. I don't like people coming to my private place, and I don't want my daughter bothered. So she was sort of comparing what it would be like to have her daughter come over and do things versus continue with her current situation. So she evidenced some effort, excuse me, she evidenced some, she shows you some evidence of decisional abilities, the ability to express a choice and the ability to comparatively reason. She does. But I would argue that if you only focus on someone's ability to do those two, perform those two decisional abilities, um, your chance that you're allowing someone who actually lacks other decisional abilities to make a decision is increased. And I'll show you some data that would support that. So these are studies that we did long ago, long time ago, with patients who had dementia, most likely caused by Alzheimer's, but it was a pre-biomarker era. I have no doubt that many of them had other diseases, if not even not Alzheimer's. And then their caregivers, who were a comparison group of persons who were considered cognitively unimpaired. Um, and we had them go through some structured assessments of decisional ability. I won't give you what the decision was about taking an Alzheimer's treatment. And so all the patients individually, privately, we assessed their ability to make a decision to use an Alzheimer's disease treatment. And we did the same with the caregiver on behalf of the patient. And we measured their ability to express a choice, to do what this person said. No, I don't want my daughter coming over. Or, yeah, I do. And what you can see here is that basically every single one of the patients, but for one, were able to make a choice. We were able to present them this information about a drug to treat Alzheimer's. And all but one was able to say, I'll take it, or no, I don't want to take it. So if you use the ability to just say what you want, give you some information, do you want this or do you want that? And if your standard for assessing whether someone can make a decision is make a choice, then I would argue 97% of these patients with mild to severe stage dementia would be judged capable of making the decision. And if you say, well, I want a little reasoning here, how's having your daughter come over better than not having your daughter come over, which is what she engaged in, you get about half the people able to fully engage in comparative reasoning. Don't fret on the scores. We have this standard where we sort of have a rater listen to the interview and judge 0, 1, 2, meaning able to comparatively reason a 2, not able 0, 1, marginal. But I think for illustrative purposes, what you're saying, what I'm showing you here is that if what you rely on is someone's ability to comparatively reason through a choice, about half the patients who in the sample of mild to severe stage dementia would be judged capable of making a decision. And that, again, may be the choice you may decide ethically. All I need is a choice and some comparative reasoning. I would argue, though, that you're missing out on some other important decisional abilities. Namely, one of them is the ability to understand, the ability to take in factual material and know what it means according to some semantic map of what facts are that's in your brain. Semantic meaning knowledge of the world, and then say that back. And what I think you can see here is again the same sample of 39 patients and caregivers that only about a quarter or so of the patients showed sufficient performance and understanding to match a comparative group of caregivers. And a notable proportion were spread throughout. So in other words, what you have here is about 30, almost 40% of the patients really not able to understand the information, even though they can tell you what they want and reason through it. And I think many of you in your clinical practice can just resonate with what you've experienced. Um, So let's kind of continue on this theme. This is another study that we did also with patients and caregivers, where again, you see the majority of patients able to make a choice about taking a treatment compared to a sample of caregivers. And again, you see a majority of the caregivers fully capable of understanding, but only a small proportion of the patients able to understand. I'm sorry, I seem to be caught here. Okay, so I've kind of sort of walked you through a lot of concepts, and I'm going to start to sort of now define them. So when I've been talking about the decision-making abilities, what I've been talking about are four decisional abilities, three of which I've mentioned: the ability to communicate a choice, the ability to engage in reasoning, which we can break down into comparative and consequential reasoning, the ability to understand, and the ability to appreciate. Um, what I've done here is kind of show with the arrows and the comments how in clinical practice, what often unfolds is we ask for people, we dump a bunch of information on them, excuse my language, but we do. We ask for a choice. And then we kind of say, well, tell me why you want that. Or we even just, they say it, and we're good to go. What we fail to do typically is assess understanding and appreciation, particularly understanding. And I think if there's one key skill you should leave this talk with is how to assess whether someone understands information. If you have that in your armamentarium in the same way you have skills to assess shortness of breath, how many stairs can you climb before you get short of breath? Do you get short of breath when you lie flat on the bed? These are things that are hardwired into a good internist brain. Um, or how to assess cognition. Let me give you three words. Remember them. I'll ask you later, and in between, you do a couple of tests. To the extent that those are hardwired into your skills, the ability to assess understanding is you will make enormous progress in, I believe, conducting the ethical practice of medicine with adults. So, um, what I would suggest is that this case shows you that we need to focus on assessing people's understanding and appreciation, and only then kind of asking them, what do you want to do? And then also engaging in reasoning. And so that will give you a more robust sense of someone's decisional abilities. And with that more robust data set of this individual for this particular decision at hand, you can decide whether they have enough decisional ability to make the decision. They don't have enough decisional ability to make the decision, and someone else has to step in. Or, as is often the case with patients with mild stage dementia or mild cognitive impairment, they're somewhere in between. They're in that space of marginal capacity where someone else might be able to support them and help them to work through the decision. All right, I've been using some terms here about capacity and competency, and so now I owe you some definitions. So capacity describes the continuum of someone's decisional abilities. And I say continuum because I think you should have sort of, not should, I hope you saw from when I talked about and showed you the ways we assess understanding, reasoning, et cetera, that there's a continuum of performance along that. Yeah, and capacity describes that continuum. If I say that someone's competent or has adequate decisional capacity, I've made a judgment about their decision-making abilities, meaning in some way I assess their ability to understand, appreciate, reason, express a choice. And out of that, I made a judgment that they are good to go, which is the default. All adults are judged to have are expected to have capacity and thus judged otherwise. Or they can't, or they're somewhere in the middle. I already told you about the four decision-making abilities. In subsequent slides, I'm going to define them in greater detail. And most importantly, give you some standardized questions that you can put in your armamentarium as a clinician to assess decision ability. Again, assessments of capacity are used to make judgments of competency. So one can't escape, if you will, the ethics here at stake, namely that it is a judgment. What enters into that judgment is a thoughtful consideration of which decisional abilities you ought to assess and how you rate someone's performance on those. What's also an ethical judgment that you make is what do they need to understand in order to make a decision? For years in the history of informed consent, that topic dominated the legal and medical literature, namely, what does a person need to understand in order to make a decision? Uh, and various legal standards came and went to decide what was considered to be adequate understanding, including the famous reasonable person standard, which has now vanished from our legal and ethical lexicon. So it should be obvious to you explicitly now by this slide that when we're thinking about someone's ability to make a decision, it's specific to the decision. I'm going to give you a pearl phrase. I love this from my dear friend and colleague, Charlie Sabatino, founder and later for a number of years of the Commission on Law and Aging at the American Bar Association. And his phrase was, never end a sentence with the word capacity. So never say, Jason Karlowicz lacks capacity. Instead, you have to say Jason Karlowicz lacks capacity to enroll in this research study, to choose whether to take lecanemab, to decide whether or not to have a p-tau 217 test, to manage his simvastatin, to manage his checkbook, um, to manage an imminent risk of harm, namely the fact that the house has got more cats than any reasonable person should have, and and the bills aren't paid. Apologies to the cat owners. Voting is in there, and I put it in there to show how capacity is wrapped up in a lot of is wrapped up in our ethics and our politics. It is interesting that in many countries in the world, there is no standard of capacity to vote. Voting is a performative capacity, namely, if you want to vote, you vote, you make your choice, period. If you can't literally pick, then it's not that you lack the capacity to vote, it's that you're just not voting, you're not capable of voting. Lack the capacity, I guess. But there is no standard otherwise to decide whether you have the capacity to vote. It's a performative capacity. In other words, if I give you a ballot, can you make a choice? This runs in the face of some standards that have been out there in some of the states, the United States, et cetera. I digress. Back to our care of our patients. The instrument list here are just the variety of instruments that have been created to measure these decisions, ability to make these decisions. The one that my colleagues and I developed is called the ACE, and I put there for meds and finances, but we designed the ACE to basically to measure someone's ability to solve an everyday problem, and that stands for the assessment of capacity for everyday decision making. Namely, someone has troubles in their daily life managing finances, and you've proposed a solution, and they haven't or have accepted it, but you want to make sure that they're making that decision, that they have adequate capacity to make that decision. Okay, let's go through the decisional abilities in greater detail. The first one, and the one that I think is, again, the most, I mentioned this earlier, said this earlier, the most important ability is the ability to understand information, comprehend the meaning of information. What do words mean? It's the most common standard for competency used by the law and in the theory of informed consent. I put here impaired by deficits and various things, and don't fixate on that, because I think one of the problems is people sort of, especially because we're doctors and thoughtful people and whatnot. And so we find out, oh, just the ability to understand is associated with short-term memory. So just measure short-term memory and that'll know whether someone can understand information. And the answer to that is no, and I'll explain that more later. But I would say if you have a patient who has deficits in short-term memory, or semantic memory, which is the ability to know the meaning of words affected by aphasias, it should increase your pretest probability that this person might have trouble understanding information. I don't think there's anything unreasonable about that position. Okay, how do you assess someone's ability to understand? This is like your students. This is your takeaway slide. Um, so this is what I always say. Can you tell me in your own words what are, and then after that is whatever that factual component was under assessment. So can you tell me in your own words what are the downsides of the risks of taking donanemab? One of the anti-amyloid therapies. Oh, it causes little tiny bleeds in the brain, and if those aren't picked up, I guess you could swell your brain as well. I would argue that's a pretty good understanding of those risks. Can you tell me in your own words what are the benefits of having your daughter come over and take care of the bills? So, um, so that's how we assess the factual content. This note I have down here is any parrot can repeat verbatim. What you're looking for is the person to paraphrase the meaning of the facts. Now, I recognize there is some evidence that parrots may actually understand language the way we do. It's a controversial position, but I won't develop it in any greater detail. My point is that when someone says back in their own words, it really gives you the confidence that they get what you've been telling them, that they get it. We showed that if you give persons living with dementia a memory and organizational aid, that they actually performed better on measures of decisional ability and were more likely to be judged competent. And it wasn't because they were just kind of reading the sheet. It was because the information was there in front of them and they were able to sort of work through the information and make the decision. So that's the ability to understand. Can you tell me in your own words, what are the benefits? What are the downsides? What are the upsides, et cetera, in your own words? And again, I've shown you this before, I believe, but here you see when you assess a group of Alzheimer's patients with dementia, mild to severe stage, on the ability to make a decision about taking Alzheimer's treatment, you see how some of them perform quite well compared to their caregivers, and some of them perform quite poorly, and the rest are in the middle. Okay, reasoning. We can break reasoning into two kinds of reasoning: consequential reasoning and comparative reasoning. So consequential reasoning is manipulating information in order to identify how it can affect the individual, affect you. Um, and comparative reasoning is manipulating information in order to identify the relative merits of one thing versus another. Let me sort of just show you examples of how to assess those so you can say, oh, okay, I get what you mean. So this is the phrase I've hardwired in my head about comparative reasoning versus and consequential reasoning. So comparative reasoning, regardless of your decision about whether or not you want to have the PET scan, can you tell me in your own words how having the PET scan is better than not having it? That is the way to ask about comparative reasoning. I like the regardless of your decision because oftentimes when you're assessing someone's decisional ability, it's because they've made a choice that doesn't seem quite consonant with their values, quite aligned with what a good standard for health and well-being might be, although in the end we respect people's choices. And so oftentimes people are a little inflamed when you're sort of asking these questions. And so I like to say, look, regardless of your decision not to want to get the test, can you just tell me in your own words how having it might be better than not having it? And I like framing it where the having it is contrary to what they want to do. So they don't want to take the test. And look, they don't want to have the blood transfusion. So you say, look, regardless about your decision to not get the blood transfusion, can you tell me how having the blood transfusion might be better than not having? And the person says to you, well, a blood transfusion is violates my scriptural beliefs, my beliefs. And I cannot eat the blood of another human. It's very explicit in the Bible, and I believe that. And assuming that's a religious view that they've held consistently, I think, yeah, that makes sense for their value structure. Consequential reasoning is how might doing something affect your daily life? And again, I like to phrase that according to the thing that the person might not want to do. So, to continue on the blood transfusion example, how might having a blood transfusion affect your daily life? Well, I guess I might live because I know I am so anemic, but on the other hand, I would feel um, corrupt in the eyes of the Lord, and that would really ruin me. So there's an example of consequential reasoning. What I think is great about these STEM questions is they're agnostic to the particular decision. They're just a way to sort of organize it. I hope you're also picking up that if you learn these kind of STEM questions and become facile in using them, what oftentimes are kind of nightmare conversations that go on for a long time actually are fairly efficient and don't consume an enormous amount of clinical time. I think one of the sort of problems that many, well, not problems, I think one of the misconceptions that many clinicians have is that the more time you spend with a patient, the better care you deliver. So oftentimes I remember when I used to do inpatient medicine back when, um, I don't know when, it was like, I think it was like years ago. Anyway, the residents would say, oh, I spent an hour talking to that family. And usually I was like, that's probably about 45 minutes too long. No offense, but maybe, I'm not trying to say 15 minutes is tops. But what I find is when people spend a lot of time talking, that's exactly what happens. They spend a lot of time talking and not a lot of time listening. And they really don't know what the hell they're talking about in terms of a structured thing. So they kind of roll all over the map. It's a bit of a sideshow there. Sorry. So here is performance on measures of reasoning. And again, I hope what you can see is amongst persons who have impairments in cognition, there's a spread of performance there. I think you can also see that caregivers, depending on how they reason about things, can give you some pretty wild reasoning. I hope that you can see how, reasoning is probably one of the more sticky places to sort of rest a capacity assessment on because it obviously brings in people's values and beliefs. And I'm not trying to say there's anything wrong with having values and beliefs, but um, some sense, after you hear about them, oftentimes you wish you didn't know about them, and that's why I think the law. That's not why I think that is why the law says the standard for decisional ability is understanding. I kind of don't want to know why. I just want to know, do you get the facts? Because that's all that matters, and I think you can see why, and that makes sense from the perspective of living well in a liberal democracy. We respect people's different views about things. And we respect them so much, we even have a constitution that lays out rights that are beholden upon all persons, not citizens, persons, just adults, humans in America, are protected under the First Amendment and habeas corpus and other constitutional rights. And I'll carry on. So the next decisional ability is the ability to appreciate. And this is the ability to recognize how facts apply to you. Again, this is another very value-laden, or if you will, decision ability that draws on your values. In the practice of medicine, what we often think about when we think about appreciation in the practice of medicine is to recognize that you have the problem at hand. I wrote illness, but I suppose what I really meant was a disease, because illness is your own experience of a disease. In contrast, disease is the nosologic entity that we call a disease and bill for and whatnot. Um, so you recognize you have a disease, its effects upon you, and the effects of the risks and benefits of options for taking care of that problem or for working it up or what it might be. Um, Apropos my example about the individual who was presented the option to have a transfusion of blood to treat an acute and symptomatic anemia, um, what ability to appreciate requires you to assign values to facts. And I think the safe space for a clinician to operate is not that you think the values, excuse me, are wrong. Like I don't think that set of beliefs is correct, but just are they coherent and consistent? Or over the course of the conversation, are we kind of going all over the map here with values? Or the family, you and everyone, I've known you for years, you were always of this view, and now what's happened? And that's a big issue in some of the dementias, particularly the TDP diseases have caused frontal lobe pathology, where you have radical changes in people's social cognition and related aspects that formulate values, such that I have, for example, a patient who was once the nicest guy and caring, who was online just garnishing the family's fortune on a variety of, well, romance schemes and supplements and everything else. It can be a very difficult space to operate in, but having that nosologic diagnosis that his frontal lobes are being sorely damaged by TDP-43 disease helps to make the case that he's not capable of managing finances, and hence the judge put him under a limited guardianship for finances to avoid the impoverishment that was occurring to him and his family as he garnished their inheritance to pay the taxes on a lottery that he had won from, I don't know, Qatar or something. So to assess someone's ability to appreciate a problem, what you ask is, can you tell me in your words, what's your medical problem? So can you tell me in your own words what disease I've diagnosed you with? I actually ask that of my patients who I see at the memory center. Granted, they're at the memory center, so I say, welcome back to the memory center for your follow-up visit. Are there any problems you discuss with me, et cetera? And oftentimes they'll say, no, nothing. They'll say, well, this is the memory center. So are there any issues with your memory that you want? And then they'll, oh, well, actually, yeah, my memory is not that good, you know. And so we'll engage in this conversation about their memory, where memory is often a cover term by humans to express a variety of cognitive abilities. But and then as we sort of talk about their memory, I'll often say, so what's the disease that I've diagnosed you with that's causing these problems? And it's very interesting to see how many patients will say, oh, I've got Alzheimer's or I've got dementia or et cetera. So they appreciate their disease label. Uh, so for in the case of risks and benefits, the sort of way we frame when we think about a medical intervention, whether it's diagnostics or therapeutics, I think there are upsides, benefits, and there are downsides, risks. So regardless of your decision about treatment, about the test, about whatever that thing may be, can you tell me what you see as the benefit or the risk of it to you? So again, that's a hardwired thing. So regardless of what you think about sort of the upsides of lecanemab, can you tell me what you see of the risk of lecanemab to you? And the to you is the key thing there. It's no longer about the risk as an understanding concept, as a factual concept in the world on an FDA label, if you will, but it's about taking that factual construct and applying it to you. And in the case of humans, this is again where values enter into it, and you can see some pretty wild values at work here. You know, magical thinking, etc. Wild ideas of hope, feelings about the future that can lead people to have some wild appreciations. And I get back to my point that what you're looking for is consistency and coherence and respecting the fact that people have a variety of different values and beliefs about the world. And we, as a matter of civil discourse, need to respect them. Another way to assess appreciation is, do you believe it's possible that this treatment might benefit you? Can you tell me why? Can you tell me why not? So I hope that you've seen these structured questions really allow you to kind of finish a conversation with someone and say, um, I have a sense of their ability to appreciate, understand information, to express a choice about it, to reason through that choice, and to appreciate the information. Appreciation is an interesting issue, and I began to gesture to it with my remarks when I told you about when I see a patient back at the memory center and ask about why they're here and are there any problems that they're having that they want to discuss with me. Namely, that we have this stereotyped understanding that patients with dementia, particularly dementia caused by Alzheimer's, but, quote, lack appreciation. They're not aware of what's going on. And this slide sort of helps to support that point. Namely, these patients were presented with a treatment to treat their Alzheimer's disease, so a drug to treat Alzheimer's. And we put them through this capacity interview. What you can see is that nearly half the patients could appreciate the risk of the drug. The risk was gastrointestinal bleeding. The drug was modeled after a nonsteroidal. And what you can see here is about half the patients just couldn't see the benefit of the drug, but a proportion could see the benefit, and nearly the other half, either fully or marginally. And the comparison group of the caregivers are there to show you how they appreciate the risk and benefit of the treatment. I'll go on a bit of a sidestep here. What I find interesting is my takeaway, I hope that you take from this, that you take away from it, is um, many of you probably like me are myopes. A myope is someone who can't see distance as well. I'm able to address that by wearing two very thin plastic discs over my cornea, otherwise known as contact lenses. And with my -8 and -9 discs, I have really bad myopia. I go from being essentially unable to see the hand in front of my face to being able to see the hand in front of my face and the car in front of my car or my bicycle. And so if you ask me, how's your vision? I'd say it's pretty good. And it is pretty good. And of course, you should like go, oh God, it's such a tragedy. He lacks complete appreciation of his illness because he's a total hypermyope. And, I mean, his vision is horrible. Well, you asked me, how is my vision? And I said, well, right now my vision is good. So do I lack appreciation of my myopia? Or do I have appreciation that with adequate supports, my myopia isn't that bad? And I think that's what many patients say to us when we say to them, how are you doing? And they say, I'm doing great. And we say, oh, the tragedy of dementia. They have no awareness of what's on. Oh, it's so sad. Look at that. Shoot me if I ever have that disease. But if you then say to them things like, well, what if your wife wasn't here? They'll say, oh my God, I don't know what the hell I'd do, etc. So my pitch I made to you is that awareness, insight is a many faceted thing. And you have to sort of ask yourself awareness of what and why before you just walk away from a patient and say, oh, they have no awareness of what's going on. And this is that same study. So we asked the patients these questions. Now, this was a structured interview. It was not a clinical interview. It was done by a college-educated research coordinator. Do you have any problems with memory and thinking? And look about 2/3 like, yeah, I do. Do you think they'll get worse? About a third, like, yeah, they're going to get worse. And about a third thought they had Alzheimer's and dementia. So if you ask, people will often reveal with this particular mental illness called dementia, that they are aware of their symptoms, they're aware of their prognosis and the cause. Um, so remember, back to the beginning, if all you say is, I've got this drug to treat Alzheimer's, do you want to take it or not? And they say no, and that's all you go by. You have no idea if behind that statement of no, there's adequate understanding of the facts, let alone the ability to appreciate and reason through them. So one of the things we've done in the studies we've done of decisional ability is we have, so we do these recordings. In the research we did, we put people through these structured interviews. I've shown you the STEM questions. Those were the questions that you saw there. And we record them, and then we give them to consult liaison psychiatrists whose job is to assess decisional capacity, particularly in the inpatient setting. Oftentimes they're called in forensic cases of guardianship in the judicial setting. And they would get the interview to listen to, and they wouldn't know. They knew the patients had Alzheimer's disease. They knew they had dementia. again, all the studies I did before biomarkers, everyone that I said at Alzheimer's, I have no idea what they probably had, but I digress. Anyway, and so they knew they had dementia, but they didn't know what the severity of the dementia was at all. They did not know these patients. They just said this: listen to the interview and decide whether you think the person has enough decisional ability to make the decision, or does not have enough decisional ability. So a rating of do they have the ability to make the decision to take the treatment. And what you can see here is variation amongst the experts. One expert was kind of generous, about 60% of the patients she thought capable. Another expert was a little harsh, about a third capable, and the other guy, but I would argue I'd rather have someone trained in decisional ability to assess my decisional abilities than the first 100 names of the Sioux Falls phone book selected to do that. So if you looked at agreement between the raters, what you can see here is that in general, there was decent agreement between them and an overall agreement of 0.5. So I will now show a slide that will cause many of you to blanch, but I'd like to argue that there is some role to know what the severity of someone's cognitive impairment is, because what you could see here is that when you took the Falstein Mini-Mental score of those patients and compared the Mini-Mental score to the proportion of people that the experts judge competent, you can see here that those who had a Falstein Mini-Mental greater than 24, about three-quarters were judged competent. Those who were in the range between 19 and 23, oftentimes considered the range for quote, mild stage dementia, and between 12 and 18, more moderate. You can see here the proportion is dropping. Now, does that mean you get the Mini-Mental and say, oh, it's 10, there's no way he's competent, let's stop here? Or, oh, it's 25, he's clearly competent? Absolutely not. It just simply raises or lowers your pretest probability. You should be concerned about whether the person has adequate decision-making ability. So, um, I'm not here to bury the Mini-Mental or to praise it, but just simply to say it has a role, or the MoCA, or any other cognitive test you want to pick that is one of those omnibus measures of cognition, like the wonderfully named SLUMS, for example. They're there to give you some sense of, gee, there's some impairments. Now, being a researcher, of course, what we've done in subsequent work with patients with Parkinson's, we looked at MoCA scores, the Montreal Cognitive Assessment, and the degree that MoCA scores predicted judgment competency in patients with Parkinson's. And we saw the same kind of trend. And we looked more closely, and certainly what we found was subscores on the executive function aspects of the MoCA really drove the judgments. Again, some people say you should not show people those data. That those data are ethically wrong because what you're saying is that cognition is competency, et cetera. And one time I wrote an editorial in the Lancet about a study of hospitalized patients, which showed a similar finding. The Mini-Mental was a strong predictor of like half the patients in the hospital were judged not capable of making a treatment decision. And a letter writer wrote back and like just flamed me for like, how dare you suggest that, below 20 it's high likelihood of not being competent. And my response was, I'm not trying to say like you walk into the room and you ask the resident what's his Mini-Mental, and they say 18, and you say, well, there's no reason to bother to talk to him about his treatment. But what I am saying is that if the resident says it's 18, you really ought to be concerned that, gee, we're asking this guy to make a lot of decisions, and we really need to make sure he's has the ability to make them. So that's my soapbox. All right, back to the case. Well, the case was a person solving a problem with everyday living. And I would argue that it's a good example of, it's funny when we think about informed consent, we think about, surgery, sticking needles into our orifices or whatever, and treatments that are risky. But I would argue actually the daily practice of the care of people with dementia, with cognitive impairment, whether that's MCI or dementia, they're making a lot of decisions that seem quite ordinary and quotidian, but for their well-being and their happiness are incredibly important, namely decisions how to manage IADLs. And so that's why we designed the A's to solve that. And it's a structured interview insofar as it uses those STEM questions to assess whether someone understands their functional problem, a problem, not theirs, but just a problem, troubles managing medicines, whether they appreciate that they have it, and whether they can understand and appreciate options to manage it, the upsides and downsides, and reason through it and express a choice. And the instrument's available. We've had like 1,000 requests for it. And it's interesting. Many of the requests come from discharge planners, other people in that kind of social service setting where they have to decide whether people can sort of manage their own lives. And I've heard back from some people who've used it, and they said it put some structure around what otherwise was kind of a hurly-burly conversation, which frankly kind of would get lost in reasoning because you're getting at people's daily life and their habits and the way they like to live. And given how some people like to live, that's a weird space to go. And you really want to focus on the understanding aspects of things. And that's where I think the ACE is quite helpful. All right, let me wrap up. We've got some time for Q&A. So instruments exist that can structure how we decide someone can make a decision. And I showed you that slide with all those instruments. The ACE is one of them, the MacArthur instruments, etc. And what's important about those instruments is, and I don't use them in my clinical practice. I don't like sit there and read it. I have hardwired in my head those STEM questions. But what they focus on is someone's decisional abilities, not their status. And by status, I mean like a disease label, like MCI, et cetera. Not on reasonableness, because I don't know what the heck that is, and not on just cognition. Um, the more you become comfortable with an instrument, the more it's those, what decisional abilities you care about. Where are the impairments? They help to kind of give you a sense of the clinical significance of impairments in cognition and neuropsychiatric matters. I think getting the, I hope that, I mean, one of the goals of my colleagues in the world of capacity assessment, we used to spend a lot of time developing instruments and measuring stuff, and that there's still studies being done in that space. But I think we've moved now to how to take these constructs and put them into clinical practice. In other words, how to have a reasonable clinician say, well, gee, I think she doesn't have the ability to make this decision. Why? Well, she doesn't really understand any of the core facts. I would say that sounds like you've assessed the decisional ability. Yeah. So years ago, James Lai and I did all this work on the assessment for capacity to make everyday decisions. James is now the chief of geriatrics at Columbia University in on the Upper West Side of New York. Congratulations, I guess. um, and there's a paper I wrote in this journal called Neurosignals, which actually is a pretty nice paper that tries to sort of not tries to like it does what it says, measuring how to measure decision making capacity in cognitive impaired individuals. It's a nice overview. If you want to copy the ACE or SPACED, which are the instruments I mentioned, you can drop me a note at my Gmail. I wouldn't be done if I hadn't shamelessly self-promoted a chapter in my book that is the history of capacity assessment as it relates to the lives of persons living with dementia. And I should also shamelessly self-promote that we have a podcast called The Age of Aging, which is available on all podcast platforms. And we just dropped an episode today on the age of aging, where we interviewed Dan Gibbs. Dan is a neurologist, and he wrote a book about his life living with Alzheimer's called A Tattoo on My Brain. And I interviewed Dan maybe 2 years, 3 years ago, a couple times, and just recently interviewed him again in the company for the first time ever with his spouse and caregiver. It's a very moving interview, which shows what it is like to be a person living with Alzheimer's, particularly a person who needs the mind support that another person provides. In this case, Lois Seed, his caregiver. So that podcast is just dropped. We've got several other episodes, including Canine Care, an episode about the role of dogs in caring for and living with dementia.